I do work through my own organization, as Lesego has said, Open House Initiative, to do lots of different types of work. I didn't leave Lesego behind. I'm still doing some of the work that just he's not aware of, and a lot of women's health work, contraceptive work, termination of pregnancy work, etc. But I also work with NACOSA. NACOSA is the Networking of HIV and AIDS Community of Southern Africa. It's an NGO that started many, many, many years ago. So I'm one of the first NGOs to be involved in writing up the initial HIV NSP that we had in the country. So currently I'm working with NACOSA as a GBV technical specialist. And really my role is to capacitate healthcare workers, everybody within the healthcare workspace, but also capacitating our other stakeholders like NPA, subs, social workers, all the other relevant stakeholders that are relevant to us confronting this first pandemic, which is the GBV pandemic in our country. So I'm really happy to be with you today and to talk you through some of the concepts that link particularly GBV to our role as healthcare workers and what we can do, what we can potentially do to be able to detect more survivors and link them to appropriate care, and also, also be able to provide the necessary initial management, first line response to a lot of our patients, since they do come to us first. So I'm just gonna switch off my video, and then I wanted to say hi, and then I'll continue with the presentation. Okay, I'm trying to move my slides. They're not moving.
Just click with your mouse anywhere on your slides, then they should start moving. Thanks.
Yeah, there you go. Yes. Thank you very much. So we're just going to talk a little bit about gender-based violence. We're not going to go too deep. I think a lot of us already have a basic understanding of gender-based violence. But gender-based violence is an umbrella term that for any harmful threat or act directed at an individual or group based on actual or perceived biological sex, gender identity and or expression, sexual orientation, and or lack of adherence to varying socially constructed norms around masculinity and femininity. So as you can hear, even the definition of gender-based violence is so broad, and already starts to awaken us to all vulnerable people that may be subjected to gender-based violence in one way or another. So it's not necessarily a man to a woman or a female to a male, but there are a lot of considerations that we always need to keep in mind when we are talking about people and their vulnerabilities, as well as the diversity of the people and vulnerabilities. But we do understand that gender-based violence is rooted under structural gender inequalities, which are ultimately, the outcome of patriarchy and its systems. And we all know about the gender inequalities that we are talking about in our structures. And they may be religious structures, traditional structures, economic structures, political, whatever structure you can think of, are all based on patriarchal principles, which have created these structural gender inequalities. And this power imbalance often ends up being the catalyst of exerting violence over another person. This power imbalance that is based on these gender inequalities mainly, and also patriarchy as the root, also end up causing harm to other people who are less powerful than the other. And it's characterized by, the use of threat, or even physical violence, psychological, sexual, economic, legal, political, social, and other ways of abuse of power and control. There's a concept of obstetric violence that is picking up and gaining some momentum within the GBV space, where as healthcare workers, we need to honestly start reflecting on our practices and how we do things, and how we relate to our patients, because often we associate GBV and abuse of power and all of that with other people, but we don't bring it home and see and self-reflect and see what are the structural gender inequalities within our health system that are causing us to do things in a certain way and inadvertently also become some form of perpetrators of gender-based violence to our female patients, to our woman-bodied patients, or even queer patients for that matter, who don't necessarily identify. And some of these obstetric violence examples will include things like forced sterilizations. You know, can you imagine how many women we are forcing to sterilize without proper informed consent? Giving them proper information, because obviously we're making them getting these tubal ligations for their health reasons and health outcomes. We're worried that a subsequent pregnancy might result in problems. But how well do we actually do the informed consent processes when it comes to offering women sterilization services? There are some areas where forced sterilization is actually still reported in this country. Some healthcare facilities are, coercing patients into signing consent forms for sterilization in certain areas. So that's just one example of obstetric violence. My presentation was a bit long, so I don't want to just be stuck on one concept, but I really needed to bring home the fact that please can we start self-introspecting and looking at what barriers are we putting in place that are making women not access safe services, that are putting them at risk of GBV, including us clinicians, us medical practitioners who are abusing our own power and sexually violating patients. The stories that I hear in this work that I do are just completely hair-raising and stomach-turning, where we are working with colleagues who are actually violating and raping patients in their practices, and that is really uncalled for. And really, as healthcare providers, we need to not only do better, but we need to do something about this. It's a huge problem, and we can't be dealing with GBV only as patients coming in having been violated by somebody else, their partner or a stranger. But what about those that are being violated by our abuse of power? So yeah, and it really impacts, gender-based violence impacts an individual's life throughout their life course. I have seen babies as young as 1 month old, and I'm talking about patients I've examined, 1 month old, who has been horribly raped, horribly raped, to our data is showing the oldest person that we've recorded in our data in our programs is 98 years old. So everybody is at risk of being a victim of gender-based violence, and worse, when the systems are also made in such a way that they make people abuse their powers. It really, 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 really is horrible. I could tell you stories for days about the different types of power imbalances that exists in our society, within the health system, within the traditional healing system, within the police system. It is horrendous. The same people that we are saying we are serving to protect, to make safe, to heal, we are violating them horribly. And children is also another story, which we will actually, the next slide talks about children. Children, we define children as anybody who's below 18 years of age, and this is an international definition of children, but it also is a definition that we use in South Africa in our laws as well. 18 people below 18 years are those who we consider children. There are age groups conversations that I hope we can have an opportunity to have later stages as we continue with these kind of presentations about consent, issues of consent for children on sexual encounters and practices and all of that, but also consent for medical procedures and stuff, consent for virginity testing. You know, I'd like us to also go a little bit deeper into unpacking what the law says to us as healthcare workers and what we should keep in mind. But this is not going to be in this conversation. It will be in another conversation. The U.S. Advancing Protection and Care for Children in Adversity Strategy notes that violence against children includes all forms of physical or mental violence, injury and abuse, neglect or negligent treatment, maltreatment, exploitation, including sexual abuse. WHO has a similar definition of violence against children. Our different acts in South Africa also capture all these types of violences and more, including child pornography, using child images for distributing child images that may be deemed inappropriate, being also crimes in this country. So we also cover a similar kind of definition as the rest of the countries do, the world does. This is just a slide to show the different types of violence that children can experience. And children also experience violence from, you know, from pre-birth, even we can even argue, because there are some cultural practices, some groups who will terminate babies based on gender because they are female, because it's not what they want as a family. They don't want a girl child. So sex selection even before the baby is born, you know, that's how deep patriarchy goes, and gender inequality. It really starts from before some people are even born. And then we also systemically then name, you know, we decide to gender the babies when they're born, and gender them male or gender them female because of the genitals that they have between their legs, without, you know, knowing even what this person particularly identifies with. But I mean, this is obviously a bigger conversation that I'm starting here, because we are socialized to live in a particular way. We are socialized to gender things, to name everything. So it becomes a bit difficult when we start trying to think even beyond that, to say, how do we just let children be born and just make them dress however they want and decide to be who they want? That's another conversation as well. But then there are the more overt maltreatments that children experience, you know, including physical violence, sexual violence, bullying, cyberbullying, youth violence, the violence amongst the children at schools. Oh, it's incredible. It's really, it's phenomenal, the violent nature of how children are expressing themselves these days. It's quite scary. But it's because of the socialization that they come from. You know, we're quite a violent society. We come from apartheid. You know, a lot of our things are based on violence. We fight for everything. We fight for spaces. As feminists, we fight for, you know, so I think violence is just also innate in us, and it's there also. We socialize our children the same way. So the challenge is to change ourselves, really. But children also experience intimate partner violence. We've seen cases of 15, 16, and remember the definition of children, right? Everybody who's below 18, 16, 17, 18, people who can legally consent to violence, even 15 and 14 and 15-year-old, age groups that can consent for sex, that can legally consent for sex. There's a lot of violence that's happening in those relationships too. And we are not aware, and we're not doing enough. We're not, we don't have programs that address that intimate partner violence amongst those young people. Our intimate partner violence messaging is really targeted more at the older population, but not at our young people. And I mean, we would be lying to ourselves if we thought our children are not having relationships and not having sex for that matter. So, but yet we don't respond enough to them. I'm not gonna go through again the examples of violence against children. I think I've given examples in the previous slide, but this just also sums up some of the ones that I didn't get to. Child marriage. Child marriage is also a huge problem. Eastern Cape and KZN, huge problems right now in this country, 2022, with child marriages and families selling girl children to other families. For marriage and sex and all of these things. So these things are right in our faces. Trafficking of children. It has become a thing. I mean, every second video you see these days on social media is a child being snatched. We are living in that society. It's chilling. It's chilling to the body to realize the kind of society we are, and the different shades of society that we have. So just the quick stats. So, and I'm not going to do the quiz. I'll just go straight to the response. I want you to see the stats. 1 in 3 women will experience physical and or sexual violence from a partner, or sexual violence from a non-partner in their life. In their life. That is chilling. This means almost literally every third person, the woman that you know, has experienced some kind of violence, physical or sexual. We're not even going to emotional and financial and psychological, and we're not even going there. We just call physical and sexual violence by a partner or a non-partner. This is chilling, and it's alarming, and it should shock all of us. These are also some more stats. Sorry, I just want to try and move my, can't see the heading very well. But this is basically just some stats also to show you the global picture of what's happening in terms of violence. When we talk about violence, 31% of women aged 15 to 49 and 30% of women 15 and older have been subjected to physical or sexual violence from any current or former partner, male partner, or they've experienced sexual violence from a non-partner, like a stranger, acquaintance, friends, peers, teachers, neighbors, family members, doctors, nurses. All have experienced even both of them. And this is, we're only talking sexual and physical. Like I said, we're not even talking the other types of violences that happen. And these stats are for people who are 15 years and above. This is alarming, and it's really chilling, and yeah, it really is a scary piece of information. So this is to show lifetime prevalence versus prevalence in the last year, in the last 12 months. You can see, and I don't necessarily want to go through the slide in those details, because I'd like to also get to other slides. But intimate partner violence, 1 in 4 ever married or partner adolescent girl in the youngest age cohort, 15 to 19, is estimated to have already been subjected to physical and or sexual violence from an intimate partner at least once in their lifetime. This is really, really, really chilling. And it links exactly to what I was saying before about our interventions missing out this particular age cohort. Even the 14, 12, 30, people who can legally consent to have sex with somebody, our programs are not targeted at. Even our stats here doesn't even include them when we talk about intimate partner violence, but also because our age of sex consent are different in different parts of the world. So we usually talk about adolescent girls 15 years and above. Yeah, and this is just some stats about children as well, to show 1 out of 2 children suffer from a form of violence each year. So every second child, 1 billion children around the world, every second child suffers some form of violence each year. There are different types. That are, nearly 3 in 4 children, or 300 million children aged 2 to 4 years regularly suffer physical punishment and or psychological violence at the hands of a parent or a caregiver. 1 in 3 students aged 11 to 15 years suffer bullying in the past month. This was published in 2020. 1 in 4 children aged under 5 years live with a mother who is a victim of intimate partner violence. 1 in 3 students aged 13 to 15 years were in a physical fight in the past year. This is chilling stats. And what are we doing about it? I'm not going to go to the other side of the slide. I'm just looking at time. This is just a snapshot of what we have seen in the program. So NACOSA works in 7 provinces, 14 districts, 60 sub-districts, and we are currently supporting 131 public health facilities in South Africa to support survivors and victims and patients who are coming for post-violence care services within the public health system. So this data that I'm presenting now is from our own program, as I already told you the size of our program. So we reach a lot of young people. We've got a big program, which I'll tell you a little bit about, that's got 2 arms of the program, the response program that primarily works with in the health system and the health ecosystem. Well, both of them do, but the facilities wise, where we help patients who experience violence through first response services, linkage officer services, case managers, social workers who are offering psychosocial support. And then we also assist by capacitating healthcare workers on managing patients properly who are physical violence cases or domestic violence injuries, physical injuries, but also who are sexual violence survivors. So we also do a lot of that kind of training as well. So in our program, in our financial year, we are USAID funded. By the way, so financial year for USAID programs is October to end of September. So if we're looking at our last financial year data only, we've seen 24,787 survivors of all types of GBV in health facilities, in public health facilities across the country. Like I said, we are only in 131 healthcare facilities, so we're not in all, so we're not capturing all. Even in these facilities, there are gaps because we realize we are mostly at places that offer the post-violence care services. So our model now is also to decentralize our care, to go into casualties, to go into PHCs and find survivors and make sure that they get linked to appropriate healthcare services. So through our activities, we've reached that number of patients. 50% were adolescent girls and young women between 10 and 24 years. So they form the bulk of survivors of violence. That's a big number. Of these, 54% experienced sexual violence, while 46% experienced domestic violence. And we're using domestic violence here loosely as a term that encompasses your emotional, psychological, financial, physical, and everything in intimate partner violence that is not sexual. So we've covered it all under domestic violence as we present this data. But yeah, about 54% sexual violence, 46% are all those other types of violences, which we're calling domestic violence. 78% of GBV survivors know their perpetrators. Think about that for a second. 78% of the patients that we are seeing know their perpetrators. And of those, 41% of them are either their current partners or ex-partners. So it's an intimate partner violence. It's a huge number. And we do know the sequelae of GBV as it relates to health. It's got a lot of consequences, health consequences, social consequences, psychological consequences, economic consequences. It's got a lot of consequences. But from a health perspective, it can lead to injuries, which, you know, GBV is totally preventable, but we spend so much money in the health system responding to violence, you know, in the form of injuries, HIV, STIs, unwanted pregnancies, school dropouts, substance abuse, mental health issues. A lot of people are suffering from anxiety and depression. People are suicidal, all as a result. People are using substances, people are on drugs, people have all sorts of mental health issues because they experienced gender-based violence. They experienced violence. This is really horrific. And imagine all of these things are so preventable if we could change how we do things one step at a time. We could save so much money within the health system that we can actually start doing proper medicine and not just always be concentrating on reactive, reactive responses. We could do proper medicine where we are doing a lot of preventative stuff, research, evidence-based stuff, more complex cases and things like that. But because we have socialized violence so much, we also divert the money that we could potentially use to do more things and train even more healthcare providers to reach more people. I'm going to skip this slide because it's a snapshot. It's also a snapshot, but this comes from Stats SA. I will make these slides available for people for the platform, so it will be available for people to refer back to. But this is also just some stats just to show you the picture of what is happening in our country. We spoke about the life cycle and how that it can affect you. Violence is perpetrated from pre-birth all the way to a person's, till a person dies, however age that person is going to die. And it's really sad. And our systems, our traditions, our religious practices, our everything also pour petrol to that fire with certain practices and certain rituals and certain things that just perpetuate, including the healthcare practices, where some of our services have become so pervasive. We're offering contraceptive services, implants or IUDs or whatever it is, and we subject our patients to non-consensual vaginal examinations. We are also contributing to this problem. And often there's a power imbalance between a clinician and a patient. So they don't know anatomy. They think it's part of what needs to happen. So they don't know. And sometimes they're even they're ashamed to talk about it, to tell anyone about it, that they were violated by a healthcare worker because they went to consult. So we make life very difficult for women, female-bodied people. We really make life difficult, and we don't explain things, and we put them in positions of vulnerability in everything we do, including the healthcare that we give. So when we talk about some health outcomes, some statistics that are related to health, 1 in 3 women have been coerced into sex. We spoke about that. 1 in 4 girls' first sexual encounter is unwanted. Take a minute and think about that. There's a 1.5 increased likelihood that a woman who experienced intimate partner violence will acquire HIV, 1.5 higher than an average person. 47% of males living with HIV aged 15 and older are on ART, compared with 60% among females. We know men have a very low health-seeking behavior, completely. We know that. And women carry the brunt of HIV, from diagnosis to treatment, to if they carry to even caring for other people who have HIV and reminding people about taking pills and all of that. The burden falls on women. So we need to also start bringing GBV programming or capacity building or something that works with boys and men. When we're talking men's health, when we're talking about circumcision programs, we need to bring in an angle of what are we teaching the boy child? What are we capacitating the boy child about GBV, about power, about how to treat women, what are we doing? As health programs that we do actually reach men? What are we doing to capacitate those men so that they are not abusers? Because unfortunately, we are living with abusers in our families, in our homes, in our spaces. Exposure to GBV, particularly intimate partner violence, is associated with lower ART use and half the odds of self-reported ART adherence and significantly worsened viral suppression amongst women. We know some women are scared to go to the clinic to go collect their pills because their partners, if they find out they have HIV, they are going to beat them. We know, or they get beaten. We know some people whose pills get taken and flushed down the toilet by their male partners as part of the violent acts. So there's so many intertwining themes that go together with HIV outcomes, HIV as a driver, HIV as a consequence, HIV in the path, and GBV. There's a lot of, so that's why I say we really need to do better as a health system in our programming, to start bringing, in our VMMC program, where I worked quite a lot in as well. We have sessions where it's group sessions, they talk about whatever, STIs, HIV, substance abuse, all these things. That is a perfect opportunity for us to start having conversations about GBV with boys and men who are coming for circumcision services. So there's so much that we can do. Our HIV positive men who are on treatment, what are we doing as healthcare workers to have conversations, constructive conversations, so that we're building better families, better societies, better communities, better everything. Again, this is to highlight the importance of looking at HIV and GBV together. So when we talk about prevention, and when we're talking about HIV as an HIV program and prevention programs, And our prevention programs range from HIV testing, to, messaging, to all of that, to PrEP, to PEP after exposure, after rape or exposure, to social behavioral change programs like your No Means No program or Stepping Stones. We're talking broadly when we're talking about prevention programs for HIV. All of those programs are a doorway and an opportunity for us to intervene when it comes to GBV. So in our evidence-based social behavior programs, we start talking about GBV there. Our No Means No program, Stepping Stones, we start talking about GBV there, harmful gender norms, harmful social and traditional practice. Start those conversations in those sessions that we are holding to teach people about HIV, to teach young people about safe sexual practices, PrEP, all of those things. We teach all of those things in those interventions. But also at the clinical point of these services. So your PrEP services, your PEP services, those are also opportunity points for you to be able to pick up survivors, people who need to be linked for further care, because people who have experienced violence need further care. They need medical care, they need psychosocial care, they need legal support, even maybe, they need lots of things. So these service points that we are offering our HIV services in should become doorways where we are picking up survivors and we are linking them to the rest of the services. We don't have to do it all ourselves. We don't have to be the clinical forensic person and do the JTA, then do all of those. No. You don't have to do that. But just identify them and link them appropriately so that somebody else who knows how to do that will then continue with the rest of the care. So and we can look at the cascade throughout with the same lens at the testing station. I mean, we talk a lot about index testing when we're talking about testing, because we're trying to find all these HIV positive people for our 95, 95, 95 strategy. But do we pause for a second and think, okay, where do we intersect with violence? Because for us, doing index testing, not just indexing, all testing, what are we doing? Are we supporting this person enough that I'm testing, this woman that is in front of me, that I'm offering HIV testing? Am I offering them enough support, more than just this finger prick and a result at the end and a link to act? What are the consequences of this result that I'm trying to get her to know her status? Is she safe? Is she going to be able to disclose to anyone? Does she have a support structure? Because like I said, HIV can be either a propeller or even a consequence of violence. When men find out that their partners are HIV positive, some of them experience violence just because they found out that the status of the partner is positive. And then the other side of the coin is that a lot of women who are in intimate partner violence relations, they are actually at a higher risk of getting HIV than through rape or through any of this, simply because of the power dynamics. And they also have a decreased ability, I'm going to use ability for lack of a better word now, to consent for condom use, because they are in an intimate relationship with this person. And the power dynamics are such a way that if you introduce condoms, what does it mean? Are you cheating? That is a source of violence as well. So there's just so many ways that we need to serve our patients better, to make sure that they still offer our services, still do the things that we need to do, but just make sure that they are supported. And like I said, you don't need to do it just yourself all. Just refer them to the social worker, refer them somewhere else so that somebody else can help them be safe and not end up as a femicide statistic. Care and treatment, same principles again apply to care and treatment programming. Men have a low health-seeking behavior, we know, and therefore they access treatment less than their female partners, we know. But we do have opportunities, as I said, in other prevention programs, your VMMC, where we find men, where we usually find men and even link them to treatment and care. So why are we not using that opportunity as well for the same men to start having GBV conversations with them? Some of them are, in fact, survivors themselves, by the way. Some of them are survivors themselves, because patriarchy, unfortunately, is a problem for everybody. It is a systemic thing that has made masculinity the powerful, the all whatever, but unfortunately it also harms men, because if you don't live in a certain way, if you are not a particular kind of man, if you know the standard of this manhood of patriarchy is also harming our own men. And that's why we also see such high rates of interpersonal common assault violences in our casualties amongst men, because they also have a lot of unresolved issues that we are not paying attention to. They themselves, some of them were survivors of child sexual abuse, child physical abuse, child emotional abuse, and all of that, and did not get the opportunity to be linked for care and help, and end up becoming abusers and violators themselves. This slide is just basically to talk about exactly what I was talking about, the structural drivers of HIV and intimate partner violence, exactly what I was talking about. So on the right side of the screen, men using violence, having either been exposed to it in childhood, clustering that with risky behavior that some men have, you know, binge drinking, all of that, concurrent multiple sexual partners, transactional sex mixed with that, you know, contribute to a man, contribute, hear my words carefully, contribute, they are not causers, they are contributors to men exhibiting violent behavior. So we've got a lot of work, my friends and colleagues, we've got a lot of work, because we have to do work with men as well. As healthcare workers, we have to identify survivors, all survivors, including men, and also divert them to programs that are going to be helpful to them. We really have a lot of work. And then women also, same kind of social drivers or structural social drivers as men. Some experienced violence in childhood, some witnessed violence, even with the boys. Some witnessed violence in childhood, and then some psychological, other factors that women experience, contributing to ill mental health, you know, anxiety, depression, post-traumatic stress, all of these other distress factors, combined together with increased sexual risk, either being having risky behavior, you know, drinking, all-nighters, having multiple concurrent partners, transactional sex without proper protective measures, those kind of things also contribute to women being more likely to being victims of gender-based violence. So they are, it's very broad, all of this. This is just to, I have to keep minding the time. This is also just to re-emphasize the health outcomes that are related to GBV. So they are not only just HIV. I was giving you one example when I was talking about the HIV cascade out from prevention programs all the way to care and treatment. There are other health outcomes that are not necessarily HIV related. People who experience gender-based violence are twice as likely to experience depression than those who are not experiencing gender-based violence. So mental health consequences are also extremely there. And again, you can do a mental health cascade as well. What are we doing for prevention, for mental health issues? What are we doing for um, blah, blah, blah? How do we screen people for mental health? What services are available from community level to health facility? What care and treatment facilities are available? We can do all of that for every single health outcome that I'm telling you here. And all of them, GBV falls in there. Mental health prevention programs, GBV falls definitely there. Mental health screening programs, GBV falls there. So I'm just trying to show you how broad and vast the topic of GBV is, and it affects us in every single way, especially as healthcare workers, in every single service that we are providing. Sexual reproductive health. Uh, Women experiencing GBV are 16% more likely to have low birth weight babies. And we already spoke about the HIV risk, but also a 1.5 times higher risk of getting other STIs besides HIV. 42% of women who have experienced physical or sexual violence at the hands of their partner have experienced injuries as a result of the violence. 42%. So our health budget is going to these 42% people who are experiencing injuries that need healthcare intervention. That's a lot. And 38% of all murders of women globally were reported as being committed by intimate partners. Yeah, so that's the grimmest outcome of GBV is death. And there's so much we can talk about. There's so much that we can talk about, but because of limited time, and I also want to give an opportunity for us to interact and things, I'm just going to skim through the next few slides, because a lot of the things we've already spoken about. Here again is what can we do to find cases and to link them, find cases of GBV. And remember, it's not only women, it's not only children, there's also men, it is sex workers, it is LGBTQI people, it is people with disabilities, it's everybody we come into contact with. How do we identify them? What screening tools do we have in place as part of our routine healthcare that we provide to screen people for violence? But most importantly is, before we even screen anyone for violence, before you even want to do something, you need to have a referral system in place. You have to have a referral system in place, because you don't want to be asking somebody about violence. And then the next thing, you're just writing a referral letter and say, go to your nearest clinic. That is not helpful. It's not active referral. It's not helping that person in any way, shape, or form. You need to have active referral systems. Know exactly when you are saying go to the nearest clinic, you are saying to them, go to casualty department, ask for sister whoever, or ask for a social worker, or ask for, and when you get there, tell them you came from doctor, whatever, have a proper active referral pathway in place, so that we don't lose patients in between, because we also know how traumatic our health system is in losing patients, because wow, we've got a lot of red tape in our systems, especially in our public health system. Patients go from pillar to post, and end up not even getting certain services. So having an active referral pathway is very important for all points in this cascade. Like I said, I'm not going to go deep into that. So there are some GBV priority areas that we are trying to offer more support to, simply because we are USAID funded, and USAID supports a lot of HIV programming, but does not limit us to working with other spheres of the health sector. We want to work with everybody. As I showed you, the health outcomes are across the board. They are not just HIV related. But by virtue of where I am right now, and fortunately the resources that we have through the funding, we are able to do a lot more work with the HIV district support partner organizations like your ANOVA, Broadreach, yeah, all of them. So they are a low-hanging fruit for us, but we also work with everybody else who wants to work with us, we work with. So, but our priority is really to strengthen the IPV, identification, supporting, and all of that of our patients, especially within the context of our prevention programs, our testing programs, and our care and treatment programs. And we're doing this through training healthcare workers to do routine inquiry or clinical inquiry. So routine inquiry would be if you had a script that you ask every single patient who comes into your practice. It can be 3 questions or 1 question even, whatever it is, but you ask everybody regardless of what they're coming in for. That would be routine inquiry for violence. Clinical inquiry is when you have a suspicion because of whatever. You've got a clinical suspicion, maybe because of the history that this person is telling you, or the signs and symptoms. Maybe she's coming with a bruise in a very funny place, or whatever you're seeing her cracked phone, and whatever it is, but you are getting a suspicion that this person is experiencing violence. And then you would ask those questions in those settings. So those are the types of ways that you can include that in your practice. You can either do routine inquiry for all your patients, or you can do clinical inquiry if you suspect, especially, if you are in private practice or even in public health practice, primary health care. If you have somebody who's chronically coming in with a chronic headache, chronic depression, mental health problems, chronic whatever, and it's just not moving along. That should give you a flag to say maybe there's something deeper going on here. And then you do clinical inquiry and you start asking questions about how is the situation at home, in an ethical way, in a non-invasive way, in a non-judgmental way, so that the person can see that you're asking because you want to help. And remember what I said, if you don't have a referral system in place, don't even ask, because you might be doing more harm by re-traumatizing the person again. Yeah, and then we also, other priority is, like I said, we can talk for days. I can talk for days about GBV and all of that. So I'm trying to move fast. Our other priorities, providing post-violence clinical care services and HIV care and treatment sites. We do support post-violence care facilities like your Tutuzela care centers, your clinical forensic medicine, your casualty, or wherever violence cases are seen. But we also making sure that our services also reach care and treatment sites. We also want to capacitate those clinicians who are offering care and treatment services to be able to also at least offer the minimum package of care, screen for STIs, give you STI prophylaxis if it's a, fresh rape case, for instance, give emergency contraceptives, PEP, just to do the basics before the person gets to the Tutuzela care center, because sometimes the systems makes it long for the survivor to reach the care where they are going to eventually get all the services. So we're working a lot on that, and we're doing this through direct service delivery, as I said, through our first responders and case managers, etc. But we are also doing it a lot through technical support and training of healthcare providers. And then we also want to improve linkage between community-based HIV and GBV prevention interventions with the post-violence care services. So whenever we're having our stepping stone and our prevention program, Our target there is like 200,000. So it's a lot of young people that we are meeting. So we know these young people, and the stats I showed you, are experiencing violence. They are experiencing violence. So we are really working hard on improving case identification in those platforms to post-violence care services, and also just to get post-violence care service knowledge in communities to be known that there is this facility. These are the types of services you can get from there. This is what GBV is. This is what IPV is. This is what violence against children is. This is what the law says. This is to go and train people, and legal literacy of people in communities, health literacy. We want to penetrate communities, and we're doing that. And then we also want to improve the monitoring of GBV case identification, prevention, and response. So currently, I'm involved with the GBVF NSP pillars. I'm not sure if you even know about that. There is a national GBV strategic plan in South Africa, and we've got there are different pillars. There are six pillars. There are six pillars. The first one is on accountability, coordination, and leadership. The second one is on prevention and social cohesion. The third one is safety, criminal justice, that kind of thing. Safety and justice. Fourth one is response and care. Fifth one is economic strengthening, economic support. Yeah. And then the last one is research and information management. So I'm currently supporting Gauteng province, but I'm also involved in the other provinces in Pillar 6, which is research and information management. So we are trying to strengthen how we identify cases, how we triangulate data between what health has, what the police have, what the NPA have, what DSD has, to try and bring all of that data together so that we have a more cleaner data to talk about, and we know the true burden of GBV, because right now we are all using different definitions, different indicators to try and explain GBV. So we're involved also in that pillar, and we're trying to strengthen that activity. I'm going to skip through this because I've spoken about it. This slide talks about the minimum requirements that must be in place before you ask about violence. So we always say you first need to have an approach. You need to be able to receive a disclosure safely without traumatizing the patient again. And we use the WHO LIVES approach, the World Health Organization's LIVES approach. LIVES stands for listen, inquire, validate, enhance safety, and support. I think there's a slide that I'll quickly show. And basically, you need to have systems in place to be able to eventually end up with a successful linkage to other services. So it mustn't just be a by the way thing. It needs to be a thought through process, because we don't want to put our patients through more harm because they've already been through a lot of harm. So this is what I wanted to highlight on that. So we are doing a lot of these trainings, lives trainings. I don't know if some of you might have heard of them. Trying to reach as many people as possible who are potential first-line supporters or potential people who can receive a disclosure. And this can be anyone, by the way, right? But when WHO developed it initially, they had the health system and the criminal justice system in mind. And it's really an approach. It's not like a scientific thing. It's an approach so that you are responding appropriately to receiving that disclosure. So you listen with empathy and no judgment. No judgment. No, what were you wearing? Why did you go to that bar? No, why are you staying? No judgment. You listen with no judgment. And then you inquire about this person's immediate concerns and needs. Because as healthcare providers, we are very quick to respond because we think we know what this person needs. This person needs PEP, emergency contraceptive, bandages. They need that, and they need to be quickly referred to the social worker. That's a thing. Us healthcare workers are really reactive in how we respond. We don't listen to our patients, and we don't hear what they need right now and what they are scared of right now and concerned about. Half the time people are worrying about, a survivor, somebody disclosing to you about violence might be telling you because their actual worry is that the child is being picked up by the dad today, and whatever the case may be. There's a child involved and there's an immediate need that they need to address now. Some of them is literally, I'm here now and my child is at, I need to pick them up. Sure. I hope you can still hear me. My sound is also now giving me problems.
Yeah, sorry about that. We can hear you. Yeah.
Okay, great. Yeah. So we need to respond to this person's immediate needs and concerns. If they need to make a quick call before we continue with our conversation, give them the opportunity to do that, to organize, help them troubleshoot, whatever the case may be, respond to their needs and concerns and whatever concerns. And then you will tell them about the other support structures that are available or services or whatever at the end. But you really need to find out what are they most concerned about right now? What do they need right now that I can help with? And some things are literally practical, small things like borrowing them your cell phone to make that one call, or taking the landline and giving them to make that one call. Sometimes it's just that simple, as simple. And this process is so important because it how we receive disclosures sets a tone for the healing journey for the survivor. It really does. If you are receiving a disclosure in a supportive way, in a compassionate way, you are already laying a foundation, a good foundation for healing for that person. But if you are receiving a disclosure in a judgmental way, in a it's so late, why are you coming so, in a harsh way, that is the foundation that we are laying for that person's healing. So our role in receiving disclosure is so important, and that's why this training I'm so passionate about. We're training healthcare workers, we're training people. We're going to be training people from Department of Community Safety, GBV brigades. We're going to be training community health workers. We're going to be training teachers. We're going to be training, we want to get to a point of training pastors and all church people and traditional healers and traditional leaders, because anybody who's got a potential of receiving a disclosure needs to know how to receive a disclosure safe. The E stands for enhanced safety. So it's not for you to say you are not safe or you are in a dangerous position, but to check with them. Are you safe? Are you safe to go back home today? Or do you need an alternative place to stay? Can we make arrangements? And then you refer to a shelter or whatever your referral pathway says. Or if the person says, I'm safe to go home, say, okay, so how do you keep yourself safe when the violence escalates? When is he or she most violent? And they will say maybe when they're tired at the end of the day, or when they've had alcohol. Okay, what strategies can you put in place for those times when he's most triggered? Can you go to visit your friend next door? Can you maybe be on a call with a friend or your sister? Or can you go to church? Or can you do something? So you're helping them, because patients also have autonomy. They are the experts of their lives. They know what's happening. They know their support structure. They know all they need is just guidance in them analyzing their situation and making sure what they want to put in place for themselves. The wrong question to ask is, but why are you not leaving him? That is the wrong question to ask, because there are many reasons, which we can talk about another day, why people don't leave abusive relationships. And the last S is for support. So this is basically the referral pathways that I've been talking about. So whether you are referring to another healthcare worker who can examine and complete a J88 or whatever, or whether you're referring somewhere else for emergency contact, whatever, or for psychosocial support, or for shelter, or for victim empowerment, or to open a case at the police, a referral system is very important to have. The local CBOs in your area that support survivors, it's very important to have a list of that. So yeah, this is basically the approach that we follow in teaching people to receive disclosures. I already spoke about that. We have different types of facilities we are supporting, standalone facilities, integrated sites, different types of facilities. And we are more than happy to also start working with the private sector if people are interested. I want to jump all of these slides because I think we've spoken about all of these things in one way or another. So I don't necessarily want to repeat because I want to really give you an opportunity to ask questions. My presentation is longer than this, but I think this is where I would like to stop for now so that I give people an opportunity to ask questions and whatever. There's more to this presentation. There's still, I don't know how many more slides, about 10 more, it's a lot still, that I wanted to share, but I think I would stop here. Maybe another day I'll come and present about the NACOSA program and the data and yeah, the kind of data that we are seeing, because it's also very interesting data for you to see, and the technical support that we're offering to healthcare providers another day. So I know I said a lot. Listen, please pardon me.
No, it's good. It's good because firstly, thank you very much. I'm used to calling you by the first name. Okay, Dr. Babeda.
Yes, it's perfect.
No, thank you. Yeah, thank you very much. I think, I was listening quietly here and I was looking at people's comments and stuff. And I realized that you probably need to come back and maybe we need to look at how feasible, that is. But not only because I say so, I saw also a lot of comments that maybe we are not doing justice to this important topic. But yeah, maybe before you start, I want to just ask someone to make a comment. I'm not sure if he's aware that I'm going to ask him to. Dr. Sikitla Mushele, because he works in the space as well, he can just give quick commentary based on what was covered and some of the comments he has made as well. Dr. Mushele, if you are in a safe space, you may make a comment. Thanks. Yeah.
I don't know. Can you hear me?
Yes, loud and clear.
Yes, we can hear you clearly.
Yeah. Thank you for a good presentation. It was a very much detailed presentation with all the facts. I've been doing this clinical forensic, I think, for about 25 years now.
Actually, yes, Doc, I know you. yes, you and me know each other. Yes.
Yes, yeah. Now, I think as a solution, we need to sensitize almost everybody in all the departments about this gender-based violence, so they can be able to assist. And the basic thing here is empathy. So if you are empathetic, as we're saying here, if our colleagues are empathetic, then the patients are able to open up. And I've discovered that females are actually willing to talk about their violence if you give them a chance. But if your approach is not empathetic, then they are not willing to disclose. So we are going to lose most of them. And those ones who usually consult in the clinic, PHC, with assault, they actually hide the sexual assault. And the research has been done that actually most of them in Houston, out of all those who consulted, went to the police for a protection order with injuries. They never mentioned that they were also sexually assaulted. Actually, 68% never mentioned it. So this is a big number to ignore. So it shows that even those who are coming with minor injuries, they do have a problem. Unless you ask them, you will never discover them. So it is important for us to be empathetic. Every question, at least probe, how is life at home? Something like simple questions. Then you'll see once you touch that question, you'll see the patient changing now. Maybe started crying, then we can go further. So I think that was a nice presentation. Even for that hour we've presented is good. So we need to sensitize everybody, not even the healthcare professionals, police, everybody in the community.
Everybody.
Yeah, and the government is actually going to pass a law that everybody who knows about abuse and is not reporting it will be
mandatory. Yes.
Yes. So we need,
report,
we need everybody now. Okay, thanks.
Thank you.
Thank you. So sorry, Lisa, I want to hop on to what Dr. Micheledi said. So I do a lot of trainings, and I'm also answering. I'm trying to answer in the Q&A box quickly as well, but linking to what Dr. Micheledi just said. So one of our biggest priority in this financial year is to train people on mandatory reporting. Can somebody, I'm echoing somewhere. Mandatory reporting, because the law, and like I said, you know, there's many topics that we can still talk about. The law, as Dr. Micheledi is saying, is going to say, you know, it's almost signed, literally. Every adult, and that's 18 years and above, every adult who has knowledge has a duty to report. But now we can't just sit complacently. We need to also capacitate adults on how to receive disclosures properly and how to report and do that. But also be sensitive to not push away the young people from accessing healthcare services because of the mandatory duty for us to report, having to report. So having to strike that balance between how do we empower the young people who by law have been violated, but by them they say it was consensual. How do we empower them to make better empowered choices going forward? And us reporting it is not a punitive thing to them, but it's a empowering exercise more than a punitive thing for them. So it's also a conversation that we need to have. And then somebody asked a question about healthcare providers not having enough healthcare providers to see, especially survivors who need medical legal intervention, never mind just the medical part. Especially in rural areas, you know, we don't have enough doctors. We don't have enough forensic nurses. There used to be a course, forensic diploma, that was available through University of Free State, but it's been stopped because of politics that are going in the upper room there with the nursing council and everybody else. But I think it's a battle that we are going to win, we know, and we're going to get a registered qualification for nurses for forensic medicine. But for now, as through NACOSA, we are offering trainings in different provinces. We've done one in Limpopo, we've done one in Free State. We're going to KZN next for healthcare workers to be trained on basic management of survivors, including completing J88s, including, you know, yeah, just the basic things. And that's targeted solely at clinicians, so nurses, professional nurses, and doctors, and clinical associates if there are any available. Thanks.
All right, let's take Mamsi's hand. Mamsi, your hand has been up for a while. Would you like to unmute and make your comment? I see the nurses are very, very excited that the training is coming, Dr. Dlutlek. Mamsi, can you unmute? All right, Dr. Mabena, few comments which have been made on the chat. They are not in the Q&A, right? Bongekile at 1917. She says, "Good evening and thank you very much for an informative and helpful presentation. What is an approach to a person that has been in an abusive relationship for years in a way that they no longer see, so that is now a norm? And how do you then help them to see that this is not normal and they need to seek help or something?" Yeah.
You know, that is such a, it's such a difficult one. And I talk from lived experience here, where I had somebody very close die by suicide
Mm.
from an intimate partner violence situation. And it is extremely hard. It is extremely hard. All we can do is really just provide the support so that they know that there's somebody they can talk to, link them to social workers, link them to organizations where they can just start attending talks, women empowerment programs, those kind of things, so that, because ultimately it's a person's decision, right? It's their own decision what they're going to do, and because the reasons are also internal for staying in that relationship. I mean, they are beyond just financial and whatever. They are also emotional, and they are complicated. So there are many reasons why people stay. And so the best thing for us to do is to be there, support, and link them to appropriate to organizations, invite them to, women's breakfast and talks and things, maybe through engaging and listening to different voices, because there are a lot of platforms where a lot of survivors are talking, a lot of survivors are sharing their stories. And through that, through people attending that, gives a lot of people some a little bit of chutzpah to say, okay, maybe I can start thinking about leaving. There's nothing that you can physically, except for children you can do something legally, because you have a duty to report and they can remove the child from the situation. But an adult person, it is extremely hard. And sometimes, as in my example, even through it all, you still lose the battle. Yeah.
Yeah, tough one. And Mamsi just made a comment that she couldn't talk because of the network, but she wants to improve her GBV screening skills. So where does she start? Is there, I don't know, how do you want to respond to that? Yeah.
So I can try and share some of the tools that we have, but you can always Google. The World Health Organization has a lot of tools, that they've produced over the years that you can find and adapt to your own practice or your own setting or your own department, or even make it universal. So there are examples out there. But I can also always share an example that we have. But what I'm trying to say is, what I'm sending is not the end all and be all. There are many variations out there, many variations. Some have many questions, some have only literally just 3 screening questions, some have 5, so it's varied. But yeah, you can Google. WHO has a lot of resources on GBV, and I would really recommend that we start also using these platforms to access material and read more, so that we are also more equipped and educated and more aligned with what's happening in the, especially within the health space and GBV. So yeah, you can Google, you'll find, but you can contact me if you need me to share an example.
Yeah, Shifra is asking, how would you then approach a teenager who recently stated that she has been sexually abused at the age of 5 years? What support can be offered? I guess these are very not easy. There's no, one way, and it seems like health workers, more than anything, need a lot of upskilling as well on the soft skills and many other things. But
yeah. So I mean, the principle is that even our law recognizes rape even beyond 20 years, right? But anyway, we're not there. I'm not at the law, but I'm just trying to draw a picture to say there is no time limit of when a person can disclose violence. And even worse for us as healthcare workers, we are not even the legal system. There's no time limit for somebody to be linked to services to help them heal. There's no time limit. So for that case that you gave, it's a complicated example because there are so many layers to it. But you can refer them to a social worker, number one, and there are a lot of child protection organizations that work with different age groups and even older organizations working with older people. You can refer them to social workers either within the health system or within the NGO structures or the child protect or DSD or whatever, but link that child to a social worker because they are obviously going to need therapeutic interventions because clearly they're disclosing because it's something that's been sitting heavy. So we need to then direct this young person to different programs. I didn't talk about our programs. I'll talk another day. We've got a prevention arm of our programs, which we do No Means No. I spoke a little bit about it. No Means No and social asset building programs, helping young people in financial literacy, legal literacy, how to write up a CV, how to, different things and teach them about SRH as well, contraceptives and STIs and HIV and PrEP and all of that. So those survivors, we really, really want to get them into our prevention program for empowerment, more than anything for empowerment, assertiveness, they learn about assertiveness, building, boundary setting, and even physical self-defense as a last resort, obviously. So we really want those young people to be linked to our program. We are in 7 provinces, so we are only not in Northwest and in Northern Cape. All other provinces we are in, but only in 14 sub-districts or priority districts. But we can always talk and see how we can help each other if there's. But the point is, link that child to an empowering program. And if you don't know where to start, link them to a social worker. They can find those kind of programs for them. And then whether they want to open a case or something or not, the social worker can also assist with that part. Your role will come in terms of completing a J88. And remember, J88 is like a statement for a healthcare worker. So you are documenting what you are told, what you are finding, and what your conclusions are. That's it. You're not commenting about whether it happened 5 years ago or it happened now or it happened yesterday. No, you're not commenting about 5 years ago or what. No, you're commenting about what you were told, what you're seeing, and what you're finding. And that's why we do these trainings, because a lot of healthcare workers are scared to go to court because they don't know how to answer questions. They answer too much. They answer what they were not asked. So
I was there. I worked in that space for more than 10 years. I tell you,
yeah,
I enjoyed the work except going to court. That I can.
So I can teach you how to talk properly in court and how to answer succinctly and not talk long like me. Or you can talk long, but have your facts in order. So yeah, and so you can link them to a social worker. That would be your best solution if you don't have a referral pathway in place yet. And then in terms of reporting, mandatory reporting, if there are things that need to be reported, the social worker can also assist with that. But you also need to learn. One day we want to come and teach you on this platform on how to complete a Form 22, because as a healthcare provider, you have a mandatory legal obligation to report any reasonable suspicion of sexual abuse of children. So you also have a role to complete that form. So when you are referring to the social worker, you are referring with Form 22, so that you've reported the case. Yeah.
Nice. Susan is not happy with you. She's the regional training manager for Northwest. And whether you are not offering any training.
Susan must just phone me and we will talk. There was somebody who called me from Northwest. So there are ways to do it. There are ways. It's
the
just
manager
that...
for all training programs for the whole province. No. Why not?
There are ways, Susan. You can contact me. There are ways.
Yeah,
There are
and
definitely ways.
Mbulungeni says, yeah, this doctor is loaded on this topic. But as you laugh, let me see, Peggy Temba. Colleagues, let's just take these two hands and maybe sum up some of the things, and then we take it from there. There's still Lizelle's question, but Peggy Temba, are you able to unmute if you have a quick comment or question? We have less than 5 minutes to close. Peggy Temba, okay. Mpo Eni, are these false positives? Paul, Eddie, unmute. All right, no, that's fine. I think there's a lot. Yeah, you know, now I'm really caught off guard that there is a lot that needs to be discussed. And I saw your message as well, Doc. Whilst you were presenting, I was like, okay, so
now you understand, eh? Now you understand.
No, it's a lot. But maybe let's take, because I didn't even get a chance to ask my questions, which I had for you because there was just so much. But Lizelle is asking what I think is also an important question as we close. So with regards to perpetrators, how do we help them? Because there's also repeat perpetrators. I don't know, you know, your experience, and there was a lot of questions as well about stats for men. But what do we have as interventions to help people to do a U-turn and be better and good people? Yeah.
So there are a few organizations, you know, like GBV, unfortunately, is not well funded. It's not a well-funded program worldwide, I think, and mostly in our country as well. So even on the victim side, even on the perpetrator side, some people even argue that perpetrators benefit more from the system than survivors do. Because, you know, there are processes, they go to, they have a place to stay, even if it's jail, but they are fed, they get opportunities to go to school. You know, there are just so many complexities to the issue. But what I'm trying to bring home is that and again, it's the issue of compassion. A lot of perpetrators themselves were most likely victims at some point in their lives, and nothing was done to help them. There are organizations, NICDAM, DSD, is Department of Social Development, has programs for perpetrators. Department of Justice has programs, and you know, NGOs and things who are working with perpetrators. There are a lot. There are. I'm saying a lot. There are things that are available out there that we can tap into, but because there's not enough money, it's not at a big scale. So the more we make a demand from our side, and as healthcare providers as well, the more we make the demand, the more we also shine a spotlight to say, okay, we get it, but what are we doing for programming, especially young people, you know? There are a lot of children who abuse other children. The stats there are also quite high. Children who abuse other children. 14-year-olds who are raping 5-year-olds, you know, there's a lot of that. And there are diversion programs, you know, Teddy Becklin, there are diversion programs that are offered by different organizations, including Department of Justice and DSD, etc., that they would divert these children in. So that's why I say when we talk about mandatory reporting, we really have to unpack it as well, because it's not, it shouldn't necessarily be a punitive exercise, but it should be an exercise where we are trying to change society. So we are reporting people, including perpetrators, so that they can get help one way or another. And we're reporting the survivors so that they can get help one way or another. So we shouldn't find a law to be imposing, but we should try and deal with everything with compassion, to say we want to fix society with our interventions and not be punitive in what we do. So like I said, the services are there, but they are not at a big scale. Yeah.
Yeah, so yeah, colleagues, I think that I will discuss with Dr. Mabena to see, because going forward, we had planned to reduce the number of webinars because it's time to rest and Christmas. But if she is available, then yeah, we will ask her to come back probably next week or something, and then maybe she can complete. She can complete. She can complete the presentation, and then maybe we will have more, take out more from her awesome brain, which I think has a lot to give. I have known her for more than 10 years, but I think she has found a place where she's very passionate. I can tell you, I know her. She was in the circumcision thing, but this time, as you speak, I can feel your power. I can feel your energy. And when we are born, we all strive to find that place. You know, when I teach HIV, I mean, I'm like a fish in water. And today I was listening, I was like, okay, Ndrodleng has found something she's passionate about. And please just continue doing great work. And really, it's a blessing for all of us. And I think we are going to get so much more from you. Yeah. Colleagues, have a great evening. Ndrodleng, your closing remarks and say bye-bye to the colleagues. Yeah.
I just want to say thank you so much. Like, there were so many people on this call. I didn't
And they're
expect
still
that.
here.
And they're still here. And they're
Yeah.
still here. I saw a lot of some of my colleagues, some of the people I've been training. I've seen you all. I really appreciate the support. And I think we have found a platform of disseminating this information finally. So I think thank you so much for being here and staying all this time. And I'm looking forward to coming back. There's a whole lot more. There's a whole lot more. That was just the tip of the iceberg. But yeah, thank you so much.